Serge, thank you very much for the invitation. And I must say that Ruben has taken away my thunder and presented already what I'm going to present, but I assume that if you hear it twice, it may stay. With that said, let me start. Okay. By way of disclosure, I work with several companies. So this was stated, but I'll just repeat the statement. Myelofibrosis is a relatively rare disease. About one case in 100,000, that's the incidence, the prevalence. I'm not sure it's fully known and it's fully established. There is arguments of anywhere between 4 to 6 cases and up to bigger numbers. I've heard the number of 20,000 patients alive with myelofibrosis in the US. So that's not a settled issue. As far as mechanism of pathophysiology, I would like to direct you to a paper that was published about 2 years ago, which discussed, and this is done by the group of Emmanuel Passaguet, and it actually elaborates very nicely on the interplay between the leukemic, quote-unquote, myeloproliferative stem cell and the niche or the microenvironment. And it shows very nicely, doesn't have a pointer, but, okay. It shows very nicely the effect of the leukemic myeloid cells, and in this case it will be the myeloproliferative cells, how they affect the mesenchymal stem cells in the niche, remodels them to mature into an osteoblastic altered cell, which in turn transforms to myelofibrosis and shuts off normal hematopoiesis. So it gives a very nice, not necessarily absolutely complete, explanation of the shutting off of the normal hematopoiesis and the relative advantage of the malignant hematopoiesis and the consequent, at the same time, development of fibrosis is defined as a secondary event. It's not a primary event. I don't know how many more times you want to see this slide. Other than intrigues me by one thing, the similarity in the distribution between myelofibrosis and essential thrombocythemia, and somewhat different than PV. So you wonder, what is the common link between these two and less so a polycythemia vera? And I couldn't not take the opportunity and sneak in a work that my team is doing, together with Ruben, together with Gottlieb, and hopefully eventually together with Serge. We are analyzing, okay, we looked at this and we said, it's very nice, the IPSS and the IPSS and the IPSS plus are all very nice, but they don't assess the likelihood of response or lack thereof. And surprisingly, all of these models don't have anything to do with spleen. The spleen doesn't go into the models, and neither does thrombocytopenia or myelofibrosis grade. MF doesn't go into these models. So we decided to look, what are the parameters that lead to a response or lack thereof, and we have learned that the size of the spleen is absolutely critical. Larger spleen, less response. That doesn't come in the IPSS or the DIPSS. And in a multivariate analysis, we identified 4 factors. And they include the dose of the treatment with the JAK2 inhibitors, the initial size of the spleen, the DIPSS score, and the myelofibrosis grade. And we are now expanding. This work was done on about 200 patients in collaboration with the company. We hopefully will increase it to several hundred more, and we'll get a better feel of what really is behind response or lack of response to a JAK2 inhibitor. Do we need new drugs in myelofibrosis? That is apparent, but where are some examples of why we need new drugs? And again, let me refer to the work of Serge, and Serge and Ruben have really cornered the market as far as work going on in myelofibrosis, which is okay. I'm not critical. And this is the Comfort 1 study update by Serge, which shows this is the duration. 59% of the patients achieve more than 35% reduction of tumor volume. However, the median duration of remission is about a little bit more than 2 years. For those that some degree of response, as shown in the upper curve, is ongoing, but the bulk of the, here, this is 10% response or a little more. But the patients that have the original response do not maintain it. They tend to lose it, maintain some level of response, but not as good as it was reached. So the treatment is not optimal. Granted, it has prolonged survival, and it's better than it looks here because of the crossover. This is a little bit of an unfair reflection of survival benefit because the control group also received subsequently ruxolitinib. So there is some improvement in survival, some beneficial effects, but it's not it. It can be a building block, but it's not the full story. Another work is, of course, everyone talks about transplant, so I found it necessary to quote a German paper done by Nicholas Kröger. Its deficiency is its retrospective analysis. It's not prospective analysis, but it shows fairly dismal outcome. If you look at the various DIPSS prognostic groups, it shows that the advantage of this treatment emerges only in the intermediate high, in the intermediate 2 risk or the high risk. And both of them have, yes, there is some advantage over no transplant, but it's still dismal results. Whereas in low risk and intermediate 1, the treatment is not advantageous over control. In other words, you have to think well before you send the patient to transplant, and it's not the ultimate solution, as it appears right now. This is a slide borrowed generously from Serge, and it shows JAK2 inhibitors in combination. And a variety of combinations were discussed already by Ruben, and I'll just mention or elaborate a little bit more on the hedgehog combination and the combination with the PI3 kinase inhibitors. You like these rhomboid structures, but and I think that the key rhomboid structure disappeared from the slide. Anyhow, I will talk here about 3 new targets. I will talk about the PRM-151 study by Promedio, about a JAK1 inhibitor, and the imetelstat. So 3 new drugs that I will elaborate a little bit more. Of course, we can go and spend more time and talk about HDAC inhibitors, but this is what I selected. We'll start with the JAK1 inhibitor. Dr. Mascarenhas presented it in ASH last year. My claim to fame was to be a big contributor of patients to the study. And the study is interesting with this selective JAK1 inhibitor, and we are still trying to convince the sponsors that it's worthwhile to go back to it and develop it either in single agent or in combination in myelofibrosis. And this is the reason. In this particular study, which has 2 components, a phase 1, call it a stage 1 and a stage 2, patients were treated with 100 milligrams twice daily, 200 milligrams twice daily, or 600 milligrams once daily. Subsequently, altogether, I think there were 71 patients on the study. If you look at the results, many of the patients have some level of splenic response, but greater than 35% reduction in volume was uncommon. It was seen only in a small percentage of patients at week 12 and week 24. And I think that based on that, the company concluded not active enough. And the control of symptoms was a little better. It's a little, unlike ruxolitinib, there is good matching between the two. Here there is more control of symptoms than a control of splenomegaly. The effect on the platelets, it was minimal. I would say that overall it's just a minor drop in platelets with the high dose of 600. And as far as anemia, the average actually shows improvement, although this is with the 2 doses, 100 milligrams and the 600 milligrams once a day. But this is the most important take-home message. Of 48 patients that were not transfusion dependent, perhaps 3 became transfusion dependent. It's not clear. But let's say 3 got some worsening of the anemia. of the 39 patients that were transfusion dependent, 6 became transfusion independent, and of the remaining, a very significant number, if you look at the numbers of the 3 groups of 100 twice a day, 200 twice a day, or 600 once a day, and especially the second group, which is the largest cohort, more than half of them have 50% or more reduction in transfusion requirement. So the drug has a good palliative effect on anemia, and especially on significant anemia. And I think that's the reason to have JAK, and maybe that's the mechanism of action of momelotinib, being a good JAK1 inhibitor. But this concept shouldn't be obsolete, and in a way we should be able to come back and revisit it. Now let me skip that slide. Now to the combinations, again, already mentioned by Ruben. I'll just repeat it now for you to remember it. That's a combination of ruxolitinib together with beparlisib, which is a PI3K delta. I think it's a pan-PI3K delta, not delta, pan-PI3K inhibitor from Novartis. It's a European studies led by Heinz Gislinger. And this is showing the mechanism of action. The PI3K inhibitor is involved in inhibition of the pathway of PI3 kinase through AKT, through mTOR, and so forth. And it is activated in myelofibrosis, whether in parallel or interacting with the JAK-STAT pathway that is activated as well in this disease. And in a study, I think, of 2 groups of patients, 26 patients who were previously untreated and 18 patients who were previously treated with ruxolitinib, you can see that a significant number, 77% of the patients in the previously untreated arm have significant, here is by physical examination, have significant to 50% or more reduction in spleen span. Less so in previously treated. Still, in the previously treated group who had stable disease, we have improved responses in a significant number of them. Furthermore, 9 patients. 9 patients had a complete reduction in spleen size to the point that it was unpalpable. 8 of them in the previously untreated patients, 1 in the previously treated patient. Ruben has already brought up a point of caution. This is a small phase 2 study. You don't know about patient selection. You may take the low-risk patient and with small spleens and get beautiful responses. So it needs to be confirmed. Just as a statement, Gilead is now conducting a study with us and I think Stanford using a PI3K delta inhibitor, a more selective inhibitor, the idelalisib, in this disease. PI3K delta is activated specifically in myelofibrosis. So that's an interesting study, and it's going on. Another study that was already presented by Ruben, but I'll repeat it, it's Dr. Gupta's and Venucci's studies, and that's adding a hedgehog inhibitor. In this case, again, it's a Novartis hedgehog inhibitor, sonidegib, and see if it adds to the responses. This was a study, and correct me if I'm wrong because the author is here, of 30 patients. Hedgehog pathway is involved in stem cell regulation and is activated in myelofibrosis, so there is good rationale to use it. And in a study of 30 patients, all patients, all 100%, have some degree of reduction of splenomegaly, and a substantial number of them, 70%, have more than 50% reduction of splenic span. And again, there is 12 patients had complete resolution of splenomegaly, and in 10 of them it's durable. So it's interesting. But again, a word of caution. Small study needs to be confirmed in much larger studies, and I can assure you that hedgehog inhibitors are tough. They are tough to use with loss of taste, with hair loss, with muscle cramps. For some reason, we see more of them in myelofibrosis. There are several companies now that are trying to go after this, and to mention a few, it's Pfizer is one, BMS is another one, Novartis is a third one, and Genentech is a fourth one, and maybe there is more. But this is a tough agent to work with, and it goes to address the issue, again, raised by Ruben, quality of life. This is a tough drug, so I have some reservation about the ability to use it extensively in this condition. The most important studies that I want to present is the PRM 151 by Promedio, which hopefully will start soon. Not will start soon, at my place, yes. It's already, phase 2 has already been done, and here led by Serge and Jason Gottlieb, and it's now open for a broader, wider study. And it is interesting because it's exploiting a totally different mechanism of action. As you recall, the bone marrow in myelofibrosis is defined as going through stages from MF0 to MF3, where MF3 has already extensive collagen and reticulin fibrosis and may even have elements of osteosclerosis. And consequently, the bone marrow is replaced by fibrotic tissue, and we have consequent thrombocytopenia, anemia, and bone marrow failure as part of the manifestations that we see in myelofibrosis. The drug is a recombinant protein, pentraxin-2. Pentraxin-2 is a repair protein that binds to, it's an endogenous regulator of tissue repairs. It binds to damaged tissue and facilitate healings. It also binds to activated macrophages, which otherwise have pro-fibrotic potential, and reverses their potential to what they call pro-resolutive macrophages. In other words, they facilitate healing. It's a very interesting mechanism of action. And not surprisingly, among the population of patients with myelofibrosis, there is a great deal of interest in this one. The levels of pentraxin are lower in myelofibrosis than in normal controls, and they get lower with disease progression. In this study, which had 4 arms, this is already a concluded study, which had 4 arms. One group received a single agent, 10 milligrams IV weekly. The second one got it monthly. And then there was matching groups with ruxolitinib at the same time, combined with ruxolitinib. And I will go to the results. Again, this was such an important slide and already was presented. Too bad. But the message, if I'll elaborate a little bit more on the message here. 15 patients had grade 3 myelofibrosis. 8 of them had reduction in the myelofibrosis. Let's see, 4 had reduction to grade 2, 3 to grade 1, and 1 to grade 0. Another 3 patients with grade 2 MF have reduction to grade 1. So altogether, if you wish, 11 patients had effect on fibrosis. 11 out of 25, which means 45%. This, again, was already presented by Ruben, and the slide is not very clear as far as colors, but if you try, you'll see some shades of yellow versus green. And yellow represents response, green represents stability, and what you can see is that of the 11 patients that responded, there have been also, at times, matching hematologic responses. 4 of these 11 patients have also improvement in the hemoglobin, and a larger cohort, 8 of the patients, have improvement in the platelets. So it's not just reduction in fibrosis. It has, granted, it has modest effect on the splenomegaly and the symptomatology, but it has more fundamental effect on the bone marrow. Here is a case presentation which shows a patient with fairly extensive fibrosis at the beginning, and the reduction all the way through about 8 months of treatment to MF1, and corresponding improvement in hemoglobin and platelets. So I'm happy to say that the study is now being done in a larger number of centers, and hopefully we'll be able to validate the initial very exciting observation. I'll skip that one. This study has unique features. It was not presented by Ruben. It comes from the cold parts of Mayo Clinic. It comes from Rochester and not from Scottsdale. Okay, this is a study which was led by Ayalo Teferi, and it's a study of using imetelstat, a telomerase inhibitor. Telomerase inhibitor was originally, as far as I recall, was developed by Giron and was tested in ET. And it worked. It works in almost all patients with ET. It lowers platelets. But there was some dissociation between the sophistication and the drug and the condition that was chosen. In other words, ET is not a situation that tolerates a lot of side effects. So it was then tested in a preliminary testing in myelofibrosis. Telomerase is an enzyme that is activated in certain situations. First, it's activated in progenitor hematopoietic cells only in spells, but most of the time it's subtle and not active. In somatic cells, it is inactive. What it does is it prolongs the telomere and counteracts the steady shortening of the telomere with multiple cell cycles. In the case of hematologic malignancies, in the case of myeloproliferative disease, it seems that telomerase is activated out of sequence. And the drug that was developed is a oligomer. It's like one of those old antisense molecules, this time coupled to a lipid moiety to prolong its half-life, and it has a long half-life. And in the studies that was conducted at the Mayo Clinic, there were two cohorts of patients. One cohort of 19 patients received the drug intravenously once every 3 weeks. The other one got also a first cycle with weekly times 4 and then the every 3 weeks. And the results are interesting. Keep in mind the response criteria are IWG response criteria. Those are tough to get responses there. And response, as they have seen, 36% response ranging from complete remission, partial remission, and clinical improvement. Complete remission in the IWG means normalization of the bone marrow, so it's not trivial. 4 such patients, 12.1%, have complete remission, and 3 of the 4 also had molecular remission. The remaining patients, 63%, had what was defined as stable disease. And the patient, on the average, received a significant number of cycles, 11 cycles, for the duration of treatment. And for those that have a response, it was duration of treatment was 14 months, so it's not trivial. And 27% or 9 patients are still on the study. Again, a demonstration in one case of improvement in the bone marrow fibrosis. And you can see the change in the cellularity, the change in megakaryocytes, and the change in fibrosis. Toxicity, I don't know, the rumors were hepatic toxicity, but apparently hepatic toxicity is transient and not the big issue. The myelosuppression is an issue. And the incidence of grade 3-4 thrombocytopenia was substantial, 21%. And more in Group B. Recall, Group B is the ones that got the treatment weekly for the first months, and then once a month, once every 3 cycles, every 3 weeks. So they had more. Another point is the sustained myelosuppression, a myelosuppression that lasted more than 4 weeks, was seen in a subset of the patients, and it's not trivial. So the issue, the downside of this drug is myelosuppression. The plus side is, again, somewhat similar to PRM-151, fundamental effect on the bone marrow. So it's a little different. In one set of drugs, like the JAK2 and its allies, appear to be primarily affecting the spleen and symptomatology, and here maybe we start to see effect on the fibrosis as a separate and perhaps independent effect. Well, because I wasn't mentioned, I will mention it. My claim to fame is that I started work with interferon when I was in high school. Actually, I started the first studies with interferon in myeloproliferative disorder in 1981. That's a long time, so it's difficult to remember. We chose CML at the time. It was active. Subsequently, we have demonstrated its effect on thrombocytosis. I regret that once the TKIs, the tyrosine kinase inhibitors, came in, we stopped to study the mechanism of action of interferon. So we are left with an agent that is very interesting, but we cannot define that we know well how it does what. Is it immune-mediated? Is it growth factor inhibition? Is it direct effect on signaling? Is it an effect on certain gene expression, or maybe all of the above? Those are important because certain elements can clearly be exploited in the myeloproliferative context. So with this individual glorifying myself, I will conclude the presentation. Thank you.